I work at the Homerton Hospital. We're in Hackney in East London, and I work alongside my colleague Chris Barnick, and we're a BSGE accredited Endometriosis Centre, and I have a specialist interest in endometriosis and minimal access surgery. So I'm going to be talking to you today about the role of medical treatments, the different types of medical treatments available, and potential side effects and limitations of these treatments. I'm also going to talk to you about the evidence for medical treatments at the moment, and also some future developments, which I'm sure you'll be interested to hear about. So treatment options for endometriosis are varied, and they depend on the individual. There are three sort of groups of treatment: conservative, medical, and surgical. Conservative means not taking any medicines or having surgery. Essentially, it can mean doing very little, or it can be active treatments such as pelvic physiotherapy, acupuncture, manipulating your diet, or taking laxatives to help control constipation, which can have a huge impact on endometriosis symptoms. I'm going to be spending the majority of the talk talking about medical treatments, and I'm sure you all know that surgical management is a large part of endometriosis. That can entail excision of disease, meaning to cut it out, or ablation of disease, where burning of the tissue via heat can destroy the endometriosis cells. And in reality, surgeons use a combination of techniques. And as I said before, treatment will vary from woman to woman and needs to be determined by your personal priorities. And I'd really encourage you to work with your gynaecologist and your endometriosis team to consider various factors. You might want to consider your age, your proximity to menopause, for example, whether you've started your family yet, or whether you're planning to have children or completed your family. You may have a need for contraception at this time, or it's something you might want to consider in the future, and you might be considering permanent contraception. We would also want to consider your previous treatments and any side effects that you might have experienced previously, and the potential risks for any treatment that we're offering. So what is the role of medical treatment? Well, again, it's quite varied. The main aim would be to control the symptoms of endometriosis, but there's really good evidence that endometriosis can actually be suppressed by these medical treatments as well, by downregulating the active disease that's there and causing inflammation to regress. Medical treatments can also be used in preparation for surgery, and that's normally limited to a time of about 3 to 6 months before a surgical procedure to try and shrink the disease. There's some evidence that this might result in less bleeding during the operation and make the surgery a little bit easier for your surgeon, making disease a little bit smaller and easier to excise. We often recommend medical management after surgery as well for regression of disease and recurrence after surgery. In some cases, your fertility doctor might recommend before IVF, for example, or other assisted fertility treatments, that you have a short period of treatment with a medical or hormonal preparation. And again, this is normally limited to a few months before a fertility treatment. So in terms of types of medical management, there are various types. Simple pain medications fall into the first group, and these are really common things like paracetamol and non-steroidal anti-inflammatory drugs like ibuprofen or diclofenac or naproxen. And they can be really, really effective treatments in managing your pain, but they don't get to the heart of the endometriosis, and they won't stop the active disease from progressing. Opiates are sometimes used, and these are stronger medications. Sometimes they're combined with paracetamol in compound analgesics, as we call them. So things like codidromol and cocodamol are commonly used to manage endometriosis pain, but occasionally stronger medications such as fentanyl, tramadol, or morphine are required. Generally speaking, we try and avoid opiate medications as far as possible with endometriosis, although it's not always possible. The reason for this is that opiate medications often carry the side effect of constipation, and that can often make bowel endometriosis or endometriosis around the bowel much more painful. Hormonal medications are mostly contraceptives, but there's another group of hormonal medications called GnRH analogues that I'm going to talk to you a little bit more about this evening. There are also specialist pain treatments, such as a group of medications called neuropathic medications and specialist nerve blocks as well, which are available through chronic pain teams. So I'm going to start by talking you through hormonal medications. So hormonal treatments are used to act on the endometriosis and stop its growth. What they do is either put you into a perimenopausal state, a state that's similar to pregnancy, or a male-like state. They all have a contraceptive effect, so they're not really suitable for patients trying to get pregnant, although of course there are exceptions. And as I mentioned before, there are some patients who may be advised to take hormonal treatment before fertility treatments. All hormonal drugs do carry some side effects, and I'm going to talk to you about each of those today. The main thing to consider is that most of these treatments are very similar in their effectiveness for endometriosis. So it's often going to be the side effects and whether you tolerate the medication that will determine your choice of long-term treatment. And also your preferences are extremely important, and that's something that you should be talking about with your endometriosis team and your GP. So starting with the group of drugs that mimic pregnancy, I'm sure you've all heard about combined contraceptives or the combined oral contraceptive pill, which is one of the most popular contraceptive methods. Combined contraceptives contain estrogen and progesterone in a synthetic form, but they're both female hormones that are essentially naturally produced in the body. What these contraceptives do is they stop the menstrual cycle completely, and they inhibit ovulation, which is a really important part of managing endometriosis. They also suppress the amount of estrogen in the bloodstream, which again usually means that the endometriosis will stop growing and can sometimes regress. One of the best ways of managing endometriosis symptoms is actually to limit the amount of periods that you're having, and sometimes to actually stop the periods altogether. So one way you can do this with the combined oral contraceptive pill is to take this back to back or continuously, and that's a really optimal way of managing endometriosis. Unfortunately, one of the side effects from doing that is that a lot of women will suffer from breakthrough bleeding or withdrawal bleeding, and that's where you can get irregular, moderate, light or heavy spotting, and sometimes a full bleed. So what I normally recommend is that women use the flexible extended use regimen. This means that they take the pill continuously until they experience some breakthrough bleeding. Once they do experience some bleeding, and that could be any time within a packet, it could be several months, or it could be even sometimes several years from initiating treatment. Once the bleeding starts, I would recommend stopping the pill for a short duration. So I would recommend 4 days rather than the traditional 7-day break that's recommended in the packet. This will limit the amount of bleeding and pain that you experience, and also give you a lot greater control over when you have your periods. So you can work around your holidays and work and when would be most convenient for you. After 4 days, you just start in the middle of the packet where you left off, or you could even start a new packet and just continue continuously again and take the pills back to back. And that's a really safe thing to do. And we have been managing endometriosis patients with this type of method for many, many years. Combined contraceptives are also available as a ring known as the Nuva ring, and also as a contraceptive patch. So progestogens are the second group that mimic pregnancy. Now, what happens with progestogens is that they replicate the natural female hormone progesterone, and it's the synthetic version. Essentially, it causes the endometrium, which is the lining of the womb, which is very similar to endometriosis cells, to completely regress and become very inactive and stop growing. For this reason, around 40 to 60% of women don't get any periods at all with progestogen treatments. And that's a really important way to help manage pain symptoms from endometriosis. They're usually taken continuously so that you don't have a break. And they're very, very safe to take all the way up until the menopause. And in fact, combined contraceptives nowadays are also safe to take up until the menopause or slightly beyond if contraception is still needed. So this is just a snapshot of some of the progestogens that are available on the market, but there are loads more. You might have heard of Cerazette or Desogestrel, which is one of the most commonly used mini pills or progestogen only pills. And these are tablets that you take every day without a break. Many women do not have any periods at all with these tablets, and those that do tend to have very light, painless bleeding. The Mirena IUS is also a really common used treatment for endometriosis, but there are lots of similar alternatives available now. Some of them are slightly smaller, and that means they're a little bit easier to insert if you've not had children before. The Mirena is licensed for 5 years as a contraceptive. Often we find that with endometriosis patients, they need to have the coil changed slightly earlier than others because the progesterone level does start to wear off towards the end of the license. The Depo-Provera is another really excellent treatment. It is an injection, which is primarily as a contraceptive injection, but also a really good treatment for endometriosis because it suppresses ovulation and will also stop periods in the vast majority of women. It's an injection that you can take every 12 weeks. And it's also available in an oral tablet form, which some patients might prefer, and that's known as Provera. But as I said, there are many more available, and you can talk to your GP, your gynaecologist, and your endometriosis team to try and find one that's suitable for you. Now, moving on to side effects. Unfortunately, all these medications do carry potential side effects. I have to stress that the majority of women don't suffer from significant side effects with these medications. And if they do suffer with side effects, they tend to actually improve over time and get better after the first couple of months of treatment. Really common side effects are breakthrough bleeding or irregular or prolonged bleeding at the start of treatment, and that will usually settle down within the first few months. Some women find that the medications can affect their mood, resulting in a lower mood. Nausea, headaches, acne, breast discomfort, and breast enlargement are quite common, but usually settle down over time. Some women do notice weight gain, and that's often because these tablets can stimulate your appetite. So if you keep an eye on what you're eating, then often that will help control any potential weight gain. And bloating and fluid retention are slightly rarer side effects, but occasionally you do see them. One of the most important things to stress is that these side effects are all completely reversible, and when you stop the treatment, the side effects will go away almost immediately. So I wanted to talk a little bit about a newer progestogen oral tablet called Dienogest. You might have heard about it because it has been a bit controversial because it wasn't licensed for use in the UK until relatively recently. It had been available in Europe and the UAE under the brand name Vazan, and lots of endometriosis specialists and patients have really lobbied NICE, the regulating body for medications, on the NHS in the UK over the last few years. And finally, it's been approved for NHS prescription. It's not really that different from other progestogens or mini pills. It stops ovulation, so again, it's also contraceptive. But we do think that it probably has a lower side effect profile than other progestogens. The main side effect is vaginal spotting, but that's also relatively rare. One of the most important things about this medication is that it's designed specifically for treatment of endometriosis, and that's one excellent feature. Zalkia is a name that's available under the UK prescriptions. So moving on to drugs that mimic menopause, these can be a little bit more powerful and strong and associated with slightly worsened side effects. GnRH analogues, or gonadotrophin receptor hormone analogues, stop the production of the hormones FSH, follicle stimulating hormone, and luteinizing hormone, or LH. This causes the ovaries to switch off, and it temporarily causes the ovaries to stop producing eggs and completely reduces the hormone estrogen. As a result of this, the endometrium, the lining of the womb, and the endometriosis cells don't grow at all, and your periods will stop completely on this treatment. The medication is normally given as a 3-month injection or a 1-month injection, but in some units, they may offer this medication as a nasal spray or as an oral tablet that you have to take every day. The reason these are such good treatments is because they drastically lower the estrogen levels very quickly, and that gives patients really rapid control of their symptoms. I've seen many patients, even with very severe deep endometriosis, have complete resolution of their symptoms within a few weeks of this treatment. We also tend to use this treatment before surgery, particularly for deep endometriosis, significantly affecting the bladder, the bowel, and the tubes that carry urine, the ureters, because it tends to shrink the disease to a great extent. The downside to the medication is that the low estrogen can result in quite severe menopausal side effects. So this can involve hot flushes, night sweats, and mood disturbance, which can be quite unpleasant and difficult to deal with. If they are problematic, what we normally suggest is that you take a small dose of hormone replacement therapy, HRT, alongside the injections, and this usually offsets the side effects and makes you feel a lot better. There's not any evidence that giving HRT with GnRH analogues doesn't treat the endometriosis as well, but that's something that you can discuss in detail with your doctor. The other side effects can be irregular bleeding, which tends to settle down at least by the second injection. Some women suffer from vaginal dryness, poor libido, headaches, joint stiffness, and these are all related to the low estrogen levels. Unfortunately, one of the limitations of this treatment is that it can cause thinning of the bones, particularly if treatment is given over 6 months. So that's generally our limit with this treatment. We know from research studies that the bone recovery occurs within a few weeks after stopping treatment, and generally speaking, the side effects will also take a few weeks to wear off. If we're looking at giving you longer term treatment with GnRH analogues, which is sometimes recommended in women approaching the menopause, particularly if they are keen to avoid surgery such as hysterectomy and removal of the ovaries. If we are looking at longer term treatment, then what we would normally recommend is that you use HRT, and we tend to use one called Tibolone because it's got the greatest evidence in endometriosis and tends not to flare the endometriosis up. If we're looking at treatment for several years, which is sometimes the case, what we would normally recommend is that we monitor your bone density by doing a checkup scan called a DEXA scan every 1 to 2 years whilst you're on treatment. So moving on to drugs that mimic male hormones, danazol and gestrinone stimulate the production of a male hormone similar to testosterone. They act by lowering the estrogen levels, again, quite dramatically, so you can get some menopausal side effects. Now, they're really rarely used nowadays, particularly in the UK, as the side effects are not particularly well tolerated. Patients often complain of acne and oily skin, a deepened voice, and increased body hair. Some women also complain of decreased breast size, and they also can get the menopausal symptoms that we just talked about, as with GnRH analogues. Now, most of these side effects are reversible, but there have been some cases where women's voices haven't fully recovered and that they have remained with a deepened voice. So generally, when we discuss this with patients, they don't find it acceptable. So this is something that we usually reserve as a last resort treatment in the UK. So looking at the research and the effectiveness of hormonal treatment, there are multiple trials looking at different hormonal treatments. Some compare treatments one to another, and some compare treatments with no treatment or conservative management, or with laparoscopic surgery. Now, it's important to stress that most of these trials are quite small and the quality of evidence is not that high. So there's a huge demand for randomized controlled trials, which are the highest quality evidence in the medical field to be carried out in endometriosis. Nevertheless, with these smaller trials, of which there are many, there is still really good evidence that endometriosis symptoms are controlled really well on these hormonal treatments. And from my own study at Imperial College Hospital, we found that over 50% of women could be managed medically while they weren't trying to get pregnant. There's also good evidence for shrinkage of disease, and that not only applies to superficial or peritoneal endometriosis, but also to the more severe deep form of endometriosis that can affect the bladder, bowel, and the tubes that carry urine, the ureters. There's not really any current evidence that any one treatment is better than the other, although of course the ongoing trials and trials that have just been initiated will be really important at comparing these treatments. And I really, really want to stress that there's no long-term effect on fertility here, and that all these medications are completely safe and reversible. So for lots of women with endometriosis, it becomes increasingly difficult to manage their pain symptoms. And you may find that paracetamol and ibuprofen are just not enough. So it's always important to work with your endometriosis team, or your general gynaecologist and your GP to try and work out what pain relief is going to be most effective for you. But if you're having difficulty and you're not happy with the treatment that you're on, it would be worth asking to be referred to a chronic pain clinic where you might get access to more specialist pain treatments. Now, these clinics are generally run by an anaesthetic doctor or an anaesthetist. Often with endometriosis and with chronic pain, you can develop a pain condition known as neuropathic pain. Unfortunately, what can happen is that the body becomes very accustomed to being in pain, and your body can actually send out signals to your brain repeatedly, even when there's no actual tissue injury or pain at that particular point. And this becomes very problematic. Neuropathic pain medications essentially act by blocking those pain signals to the brain. There has been some controversy recently with regards to these medications, and NICE recently released a guideline on chronic pain, which discouraged a certain group of medications use known as gabapentinoids. Gabapentin and pregabalin had been used for a long time to treat chronic pain, and for many patients they are very effective, but they can sometimes cause dependency. And there have been some recent studies that have suggested that they're not that effective for endometriosis. So the current guidelines are that we consider prescribing a low-dose antidepressant. The most commonly used one for this purpose would be a drug called amitriptyline, which is normally started really low dose at night. And I must stress that you don't have to have depression for this medication to work. The whole point is that it's given in a really low dose and can help block the nerve signals reaching the brain. You may find that they also help you sleep a little bit better if that's an issue and if pain at night is an issue. Nerve blocks can be carried out by specialist anaesthetic doctors. They are very good at examining you and finding specific trigger points on the pelvic floor or on the abdominal wall at the front of your pelvis. Unfortunately, these areas can become very tense and spasm and often cause or make worse chronic pain. So sometimes they can inject a local anaesthetic. Occasionally, they consider epidural anaesthetics as well, or injections to give you relief. These are temporary and they tend to last for a few weeks to months, but many patients find great benefit in these types of treatment. Pelvic floor physiotherapy is something that I believe very strongly in, and I see a lot of patients who get amazing results from seeing a specialist physiotherapist. What can happen in endometriosis and chronic pelvic pain is that the pelvic floor can become very tense and also spasm, and that can lead to really severe pain in the pelvis and exacerbate any menstrual pain that you're experiencing. Pelvic floor physiotherapists teach patients how to relax the pelvic floor and give you simple exercises to do to help with this purpose and recognize when your pelvic floor is tense. So that's something that I would really recommend exploring, although it may not be available in all hospitals. Psychological support is also really important. I'm sure we can all appreciate that chronic pain has a negative effect on your mental health. And it's not just your family and friends that you need support from. You need support from your workplace, particularly if you're missing time off work, or your school if you're younger. Sometimes professional help is required and counselling can be really useful. But there's also really good evidence for cognitive behavioural therapy, which is carried out by psychotherapists. Actually, it can help manage chronic pain. So that's something that might be worth exploring if you're suffering from a lot of mood problems. So moving on to talk about what might happen in the future. I'm sure you're all aware that endometriosis as a condition has been completely neglected over the last few years. Diagnostic times are really, really long, and Endometriosis UK estimate that they're approximately 8 years at present in the UK. Luckily, there has been a lot of media attention recently, and Endometriosis UK have done some great work to increase awareness of the disease. At the end of last year, the government held an all-party parliamentary hearing about endometriosis specifically, and this also got a lot of media attention, which was fantastic. This also has meant that funding for endometriosis research has increased significantly in the UK, but also in the US, which is extremely helpful. And hopefully this will lead to more medical advances in diagnosis and treatment. So talking specifically about some of the research that's going on, I'm sure some of you are aware about the pilot study that's taken place at the University of Edinburgh. Professor Andrew Horn is leading this study and recruited a small group of women to try a new drug called dichloroacetate. Now, dichloroacetate is usually used to treat metabolic conditions in children and has not been used for endometriosis treatment in the past. The reason this research is so exciting is that this is a non-hormonal treatment. So that means theoretically, if it's proven to be safe whilst you're trying to get pregnant or in pregnancy, it might be possible for women to use this and avoid hormonal treatment. This might also be a good option for women who do suffer from side effects from hormonal treatments or prefer not to take contraceptives. But I must stress that this is in the really early stages. The trial recruited 30 women in Edinburgh, which is a very, very small sample size, and was really aimed to look at whether the medication was tolerable for the women whether they experienced any side effects, and whether the drug was safe. Larger trials and randomized controlled trials will need to be carried out over the next few years. And then realistically, it will take some time for NICE to approve the drug and review the findings to decide whether or not it will approve NHS prescriptions. The initial results of the trial haven't been published as yet, but we'll all be looking out for the results. And I'm sure Endometriosis UK will update their website to reflect the results. A few patients have come forward who took part in the trial to the papers and to BBC News and have said that they had really excellent results. So that's very promising. In the US, a professor called Linda Griffith, who's most famous for implanting a human ear onto a mouse, is now focusing all her research efforts onto endometriosis, and she's a fellow sufferer. She is looking at biochemical markers and genetic markers for endometriosis, which will hopefully give us some clues about how to diagnose endometriosis through blood work or urine specimens. And also, I'm sure this will help with treatment options and give us more ideas for non-hormonal treatments. Professor Andrew Horn is also about to start the ESPRIT study, which we at the Homerton are taking part in, and this will be to compare women having diagnostic laparoscopies to diagnose endometriosis. Women will be randomized to either have treatment of endometriosis at the time of laparoscopy or be given hormonal treatments afterwards. And really, this is an important study to determine whether removal of superficial peritoneal endometriosis is actually beneficial, because many of us doubt whether removing these small lesions is actually more beneficial than taking hormonal treatments. If you're invited to take part in these trials, I would really encourage you to do so, because this is all going to help your fellow sufferers with endometriosis and hopefully lead to some breakthroughs soon. So in conclusion, medical treatments for endometriosis are generally safe and effective. The side effects are usually well tolerated, and there are lots of options available. So if you do start one medication and you don't get on with it, please talk to your GP or endometriosis team about trying another preparation, because it's very likely that actually you will find one that suits you and you're happy to continue. And hopefully, as I said before, there will be more research into new treatments and more options for you in the future. Medical treatments can potentially help you avoid the risks associated with complex surgery. That's particularly if you have deep endometriosis affecting the bladder, bowel, and the tubes that carry urine, where surgery can be slightly higher risk. Endometriosis medical management can also help you control your symptoms in the long term and help prevent recurrence of disease after surgery. Thank you very much. I understand that Emma's got some questions, and thank you all for listening and submitting your questions.
Thank you, Marianne. Thank you. What a great talk. Thank you. I'm just going to start with the questions now. Thank you to everyone who sent them in beforehand. Really appreciate it. So can endometriosis still grow when periods are stopped via the pill or through other methods? And the second part is, what happens to the scar tissue?
It's a very good question, but unfortunately, because the specific trials haven't been done, and actually that would be something incredibly difficult to study in human participants, it's very difficult to say with any certainty whether endometriosis does grow when the periods are stopped. Common sense would say that endometriosis shouldn't grow if you're not having any periods, because that would mean that you're not ovulating and your menstrual cycle has been stopped. When we look at the studies looking at medical treatments, over time there is significant shrinkage of lesions of endometriosis. So that would imply that there isn't growth. But I think there's always exceptions to cases, and it may not be the case for every woman. But certainly in my experience, I have not seen a huge number of women develop more severe endometriosis whilst they've been on hormonal treatment. The other question about scar tissue is also very interesting. Scar tissue, if it contains endometriosis cells or active endometriosis, then absolutely medical treatment will be effective in treating that. But once the fibrosis or scar tissue has formed, it's actually very difficult to get rid of it. And there aren't really any brilliant treatments for that at the moment. We know that surgery often makes things worse, although sometimes it is the only option and patients will opt to try further surgery. But with scar tissue, if the tissue is very inflamed, we know that medical treatments do reduce the amount of inflammation that's there. So it's likely that your pain will improve.
Thank you, Marianne. My next question is, if you are still bleeding on the pill, is the endometriosis still growing and activated?
Yeah, again, a very good question. I'm afraid the research studies don't really give us a definitive answer. Common sense would say that if you are not having periods, the endometriosis is unlikely to grow because you're not ovulating, and your endometriosis and your endometrial lining of the womb will be very thin. If you're taking the combined oral contraceptive pill and having a break every month, it's probably not going to be as effective as if you take it continuously, because when you're having a period or a withdrawal bleed, the reason that you are bleeding is because the lining of the womb has had an opportunity to get a little bit thick. It's probably not as thick as it would have been had you not been on any hormonal treatment. And that's why people on the pill tend to find that their periods are a lot lighter. But if the endometrium, the lining of the womb, is growing and has an opportunity to bleed, then I would assume that any endometriosis cells would be doing the same thing. So although it's better than not taking anything, generally speaking, I would recommend taking the pill continuously or using the extended pill regimen that I mentioned earlier. Having a 4-day bleed is much more convenient, much less painful, and will interrupt your life to a much lesser degree. You can also control when to have the periods, and if you're taking the packets back to back, then that means that you're having much fewer periods during the year, which is really important.
Thank you. Next question is it okay for our health and reproductive system to have our periods stopped by medication and not have periods for such a long time?
This is such a common question that patients ask us in the clinics, and I would like to reassure everyone that it is absolutely safe. The Faculty of Reproduction and Sexual Health have looked extensively at the impact of taking hormonal treatments continuously and the extended pill regimen, and they're now actually promoting that as the way that GPs should be prescribing the combined pill. There is some way to go because GPs aren't necessarily up to date on the recent guidelines. And I think some doctors don't really understand how the pill actually works to understand that it is completely safe to stop the periods completely. It's not like the blood is building up inside. What happens is that the lining of the womb, the endometrial cells, and endometriosis become very inactive and suppressed by the pill. So they don't have an opportunity to grow. So that is why the bleeding stops. So it is completely safe. And actually, in terms of fertility later on, it may be that hormonal treatment actually plays a role in protecting your fertility, because if your endometriosis is not growing, there will hopefully be less damage to the ovaries and tubes and the uterus, which can occasionally occur, particularly with more severe forms of endometriosis. So I do normally encourage women, particularly younger women, to use some kind of hormonal treatment.
Thank you. So what is the most effective treatment / pain relief for endometriosis adhesions affecting the bowel, bladder, and the the urethra post hysterectomy. And so a hysterectomy is the removal of both ovaries. They've been very specific there.
Okay, so this very much depends on the circumstances. If a hysterectomy has been performed, and a hysterectomy means removal of the womb, if that's been performed in combination with removal of the ovaries, then it's very unlikely that there will be any active endometriosis present. Once you remove the ovaries, you're essentially creating something called a surgical menopause, which means that the woman will become menopausal straight away because the amount of estrogen declines dramatically. So usually any residual pain is not actually due to active endometriosis. So hormonal treatments may not be helpful in that situation. What I would normally do is ask the patient specifically about the type of pain, because that it can be coming from various places. And if we suspect that the pain is coming from around the bowel, then there are very simple things that the patient could do in order to improve the pain. So, for example, manage their bowel habit and ensure that they're not constipated at all, and keep their poo relatively soft so that it's not straining to come through the bowel and pulling on other organs that might be stuck down. The other thing is to consider whether certain foods are aggravating the pain and the bowel symptoms. So I often talk to patients about whether they've noticed any particular foods aggravating things. But the best diets to try are often a gluten-free diet, a dairy-free diet, and something called a low FODMAP diet, which help reduce bloating in the bowel. And they're quite restrictive diets, so we don't normally do them all at once. I would normally tell the patient to try each diet for 2 to 3 weeks and be really strict with it, and then see whether or not that has any impact on their pain. If it does, they can obviously continue excluding those foods or start to introduce things slowly to work out whether or not specific foods within that group are triggering the pain. If things don't work out and actually the pain isn't affected by any of these diets, there's no point in continuing, so the patient can just eat as they normally would. But often bowel issues and dietary issues are strongly related to adhesion type pain. If the ovaries have been left behind following a hysterectomy, then hormonal treatment would usually be my go-to, because it does seem a little bit odd to give a contraceptive to someone who has had a hysterectomy. But if we're trying to stop ovulation and suppress endometriosis, then that can be really effective, even if you've had a hysterectomy. And sometimes I'll discuss with patients whether they would prefer us to remove the ovaries surgically as an alternative to taking hormonal treatment long term. The downside of that is it can be quite technically challenging. There can be risks of damaging the ureters, which are very close to the ovaries. But individualized care is really, really important, and potentially referral to a chronic pain team as well for the treatments that I discussed earlier would be hugely beneficial.
Thank you. Is laparoscopic surgery necessary if symptoms are being managed by medication?
Another really good question that I get asked a lot in the clinic. I think it again depends on your personal circumstances. If you are approaching the menopause, for example, you may want to continue with medical treatment, or you may want to consider more definitive treatments like a hysterectomy and removal of the tubes and ovaries, so that you don't have to take medication every day. Alternatively, if medical treatment is effective, it is likely that it is suppressing the disease, and therefore laparoscopic surgery isn't necessarily needed. And that's something that, again, is a personal preference. I would say that if the patient is keen to get pregnant in the near future, then laparoscopic surgery can be beneficial just before they try and start trying to get pregnant, because there is some evidence that removal of endometriosis deposits and freeing up the tubes and ovaries if they're stuck down due to adhesions can be really beneficial before trying to conceive.
Thank you. What medical options are available to those who are in the high risk category for breast cancer and have been advised not to have hormone treatment at all?
I think it would be interesting to know who had advised that you were advised not to take hormonal treatment, let's say. For women who have had breast cancer, where their breast cancer specialist or oncologist has advised them not to take hormonal treatment, I think that's slightly different to being in a high risk category for breast cancer. If you've had breast cancer and the tumour was tested and it contained hormone receptors for estrogen and or progesterone, then that would certainly be higher risk in terms of taking hormonal treatment. But everything needs to be a balance. And if you're not able to continue and you're having a poor quality of life due to endometriosis or chronic pain, then really that's a discussion that you need to have with your medical team with regards to the actual risk. And most studies looking at hormonal treatment after breast cancer actually quote really low risks of recurrence related to hormonal treatments. And many breast surgeons would certainly support giving HRT after surgery, which is potentially higher risk than taking a contraceptive. And as I said before, if you're just high risk for breast cancer, there's no evidence that progesterone increases the chances of you developing breast cancer. There's certainly evidence for combined contraceptives that contain estrogen that overall it can increase your lifetime risk by a very small amount. But there was a study looking at progesterone treatments which determined that essentially there was no increased risk. And that was a really high quality study where they combined multiple smaller studies and they combined all the data in something called a systematic review. So I think that's pretty conclusive that it's relatively safe. And I presented lots of progestogen medications. So there are hundreds available. It's one of the most accessible, and I don't think that would be very high risk.
Thank you very much, Marianne. My next question is if endometriosis has been diagnosed by laparoscopy, but symptoms are mild and manageable, would you still recommend any treatment for preventative purposes?
Again, I think this is all individualized, and you need to have a discussion with your endometriosis team and see what they advise. There are some cases where the bowel or bladder or the ureters can actually be obstructed by endometriosis, and that's something that we can pick up sometimes at laparoscopy, but most often by imaging, either by a specialist ultrasound or an MRI. And I think if you have a diagnosis of deep endometriosis in particular, it's really important to get those things excluded and make sure that there's no risk of obstruction of the bowel or blocking off of the ureters, because that can actually develop quite quickly and without symptoms. And there have been some cases where unfortunately women have lost kidney function in one kidney as a result of endometriosis that has been allowed to develop. So these are things that you need to establish, and your endometriosis team should discuss with you as part of your treatment plan. But assuming you don't have any obstruction to any organs and your symptoms are fairly minimal, there isn't a huge need to take hormonal treatment, particularly if you've completed your family and you're not worried about your fertility, or if you're approaching menopause, because after menopause and during menopause, the estrogen levels fall, so endometriosis tends not to grow and actually tends to regress as well. But if you're a little bit younger and you are planning to start a family, perhaps in the next few years, then generally I would advise that even if you don't have severe symptoms or you don't have any symptoms at all, that you do take some kind of hormonal therapy to suppress the disease.
Thank you. Are the existing treatments we have available now accessible on the NHS?
Yes is the answer. A few years ago, many of us felt very frustrated that we were unable to prescribe Dienogest because it does have incredibly good evidence for endometriosis, and it was designed for endometriosis treatment specifically, which means there's slightly more trials looking at its effectiveness. But now that NICE have finally approved Dienogest or Zalgia for prescription on the NHS, I don't think we're really missing out on any treatments versus other countries. Definitely funding needs to be invested into research to investigate and trial new treatments and ways to diagnose endometriosis. But actually, most things are available on the NHS. The chronic pain guideline that NICE released this year did recommend that we can give short courses of treatments like acupuncture on the NHS, which is a good step, but it is limited. So treatments that are more complementary, that may not have such good evidence in the medical field, are likely to need private funding.
Thank you. And my next question and the last question you've kind of touched on, but I guess it gives you just another chance if you want to say anything more on it. But what would further funding enable in regards to new treatments?
I think funding for research is essential. As I mentioned before, we need the US really to actually drive some of this research because of the pharmaceutical industry largely being based in the US. Certainly the funding has increased, but we can always have more funding to, start new research projects, funding for staff needed for research projects. But I think funding the NHS is also key, and funding the NHS more generously and more properly post-pandemic will be really important. It will increase access to endometriosis specialists and teams by increasing the number of clinics that can be provided. New endometriosis centres may also be developed with extra funding. There are currently about 50 centres in the UK registered and accredited with the BSGE, but there is space for more, and in some areas access is quite sparse and patients need to travel long distances to see a specialist. And GPs are sometimes reluctant to refer to specialists as well. And that's something that Endometriosis UK are doing a lot of work on. And certainly endometriosis teams and people like myself are certainly encouraging GPs to refer more patients to specialist teams. But we cost money, unfortunately. The way the NHS works is that it is much more expensive for a GP to refer a patient to a specialist team. And I have to say that I tend to hang on to my patients for as long as possible to make sure that actually they are happy on the treatment that they're on. And there's a lot of pressure due to funding to discharge patients back to their GP, which I don't think is always appropriate.